This
But if you
conference
just
will
look at
now
this
be
patency,
recorded.
well, just at 12 months here, so the number one is the primary patency and the two is secondary patency. So just look at the primary patency. So this is for AV fistulas at 12 months, 60% are patent versus AV graft, which is about 48%. There's not a huge difference. Both are terrible. If you get out to 2 years, look at that. It drops down for AV fistulas to 50%, for PTFE or AV grafts in the 30%. So it's hard for me to really argue for an AV fistula when both of their patencies are pretty terrible. If you look at the average catheter days before access for AV fistula, most patients have a median of 98 days on a catheter before they get their first hemodialysis access for it. So that means if you go back here 90 days, AV graft is 30 days, so it's less. So if you go back here, that means for these first interval here, these first 3 months with the AV fistula, it's not even being used. They're still living on a tunnel catheter. So for the first 3 months, they're going to be on a tunnel catheter until that AV fistula matures. And that's not even taken into account if the first fistula doesn't work and you have to do a second one. So now you restart that. Now that's 6 months of tunnel catheter use to get that AV fistula. And that's where I really think you need to be liberal and think about what the best choice is for that patient to get them off their tunnel catheter. And if PTFE or an AV graft is the right answer for them, then I wouldn't feel bad about putting that in, because ultimately it's going to limit their catheter days and their infectious risk. So AV fistula maturation, this is the big issue of getting a functional fistula. The KDOQI guidelines or the Kidney Quality Initiative guidelines talk about the rules of 600. An AV fistula graft needs 600 cc's a minute of flow to tolerate hemodialysis. It's really 800 to 1,000. Anything less than that will really not give them adequate clearance. It needs to be 6 millimeters below the skin. This can be difficult. In an upper arm, 6 millimeters is nothing. It needs to be 6 millimeters in diameter. The real issue about both these metrics is that the nurses have to be able to feel it, see it, and get a large bore needle in it successfully when they go to hemodialysis. When we look at all AV fistulas creation, so just the fistulas, there's a 62% maturation rate. I mean, that's terrible too for AV fistulas. 40% of all patients will need a second procedure. And that's my whole point, is that if you can't get the first one in and they're already on hemodialysis, now you're looking at double the length of catheter days. If they're not on dialysis and you get an early referral in the base case scenario and you're able to work on them for 6 months, now you have 6 months to try that first fistula. If it doesn't work, bring them back, do a second, maybe even do a third. As long as they're not on dialysis, you're okay, and you can continue to support the AV fistula first strategy. But if they're already on a catheter, then your decision making becomes very different. So how do we predict access maturation? Well, it's really hard. The older they are, the less likely it is to mature. Over the age of 70, the maturation rate for radiocephalics is extremely terrible. It's on the order of 12 to 20%. Poor life expectancy, this is where Dr. Proper is bringing it up. If you have renal failure and congestive heart failure, renal failure and active cancer, now your life expectancy, the best case scenario was around 5 to 6 years. If you add in age, a previous admission for heart failure or a previous admission for an arrhythmia, now your life expectancy is really on the order of 6 to 18 months. And there's two issues here. One, you need a functional cardiac output to support an AV fistula. So doing an AV fistula in these patients that are hemodynamically really compromised, it's not going to stay patent. It's going to fail. You're going to increase their life expectancy. If, in my opinion, for these patients, a tunnel catheter, even if you have to switch out that tunnel catheter on the order of every 3 to 6 months, they may need only 2 to 3 change outs before they die. And so, yes, there are these patients that it's a palliative approach, but it'll minimize their time in the hospital for procedures. It'll minimize your frustration trying to get something in them that actually stays patent. and we'll probably keep them out of the hospital and at least allow them to be at home during their last 6 to 18 months. So back to failures of maturation. We already know that age is a risk factor. Diabetes, well, half of patients are on dialysis because of diabetes. But we know that they have poor forearm maturation. Obesity, depth is a major problem here, either in the upper extremities or the forearms. Your inflow source is critical. Greater than 2 millimeters is the cutoff for an inflow source. This really becomes an issue if you have a high brachial bifurcation in the upper arm and you're going to the antecubitum and pulling off your inflow from there. Oftentimes, if there is a high bifurcation, one is dominant or one is larger, and so you definitely need a vessel that's above 2 millimeters. And as such, the larger the inflow vessel you have, the better maturation rates that you'll have. In regards to the conduit, it's really a vein diameter of 2 millimeters. Remember, it needs to dilate pretty close to around 6 millimeters. In the forearm, if it's a skinny person, you can get away with some smaller diameters, but you need a vein caliber that's above 2 millimeters. And right at 2 millimeters, 1 in 10 mature in the radiocephalic location. And that's why if they get to you not on dialysis, then you'll have an opportunity to do that fistula, knowing that there's only a 1 in 10 chance, and then move on to a more proximal if it fails. So timing and early referral, this really plays into your decision. Oops, sorry, I thought I jumped over one. This is a nice kind of diagram of who favors an AV access versus moving to a graft. AV access, of course, a younger patient will try much more aggressively. Adequate inflow artery and adequate vein. Any skin diseases, that's kind of a relative thing. History of multiple previous access infections. That's just implying that your AV access has a lower rate of infection problems than putting in a prosthetic. If they're hypercoagulable for any known condition, or if they've had multiple prior prosthetic failures. And really for me, the big issue is if I get an early referral, they have a GFR of 10 to 15, I know that I have about 6 months, barring any major problems, that I'm going to have time to do multiple AV procedures on them before they need dialysis. Scenarios that favor a prosthetic access, immediate need. I know that the maturation rates are better, the catheter days are going to be less. Morbid obesity patients is the other group that I really lean toward putting an AV graft. You can have an excellent AV access in a morbidly obese patient. It can have excellent flow rates, but the dialysis nurses can still have difficulty accessing it due to their obesity. The AV graft, the nice thing about it is it does give them another piece of feedback in order to feel it, trap it with their fingers, and get a needle successfully into it. AV fistula is one of the biggest complications, is that when the nurses access it, they go through and through and will back wall the vein. And then during dialysis, they'll get a hematoma due to being heparinized and running high flow rates. With the AV graft, it's much easier for them to get a single wall puncture and a successful access. Things that alter your AV access maturation, we talked about all those, but the biggest issue is, besides your inflow and your conduit, is that they have to have a functional pump. They have to have a good cardiac output to get that vein to mature. So timing and early referral, no doubt, if they come to you already on dialysis with a catheter, you need to get something in them that works. And if you have a home run AV fistula, that's great. But this is where a prosthetic may be the best first choice for them to mitigate catheter days. And then the next go around, you can work on an AV fistula. If they come to you with plenty of time, then by all means, you can attempt distal AV fistula creations. Or if there's no vein option, meaning we do the vein mapping, they have no vein, then I'll put them in a holding pattern. And as they start to progress and get somewhere between 1 to 2 months out from a need for dialysis, then I'll place the AV graft so that it's not placed 6 months, 12 months out, and then has time to thrombose before they even use it. So for your planning, really a cardiovascular risk assessment assessment, and that is primarily for you to kind of globally make an assessment. Is their survival 5 to 6 years, or is it 2 to 3 years? From an anatomy perspective, we use bilateral upper extremity arterial and venous studies. On the arterial study, I'm really looking for PAD in the upper extremities. The most common is a subclavian or proximal stenosis, but they'll often have disease in the brachial, radial, and ulnar arteries as well. Subjectively, you'll find things like calcified distal vessels. And then I'm looking for central venous patency, looking for any stenosis. This could be related to previous catheter use in the subclavian positions, ports, pacemakers, that type of thing. And then the superficial map will give you the size and the quality if there's any sclerosis or scarring in the tissues. Any patient has complex access that has an arm like this, multiple scars, I can't really tell what's happened to them. The venous duplex can also be terrible. In these patients, I'll still do selective upper extremity venography to look at both their superficial veins and see what their central veins look like. Here you can see there's an outflow target here that may work. There may be some scar tissue here. I would want better imaging of this. I don't see any demonstrable collaterals coming around the shoulder, so pretty low suspicion for central stenosis, but it gives me a lot more information to have that ahead of time. So creations, in the distal forearm, the most common is a radiocephalic, plugging the cephalic vein into the distal radial artery. You can also use the basilic. It's fine to harvest the basilic down the arm here and then transpose it over. Patients love it because it's on the underside of the arm and they can't see it. Dialysis nurses, on the other hand, don't like it because it's a little bit more difficult to access it in the bed. The patient really has to rotate their arm over for the nurse to get it, but that is a functional access. Brachio-cephalic AV fistula is very common, taking the cephalic on the upper arm, transposing it at the antecubitum into the brachial artery to give an inflow source. Basilic vein transposition, this can be done in a 1-stage or a 2-stage. It is a larger incision. You have to harvest the entire basilic vein along the medial aspect of the forearm, tunnel it into an anterior position, and then anastomosis. You can do that in a 1-stage to see if it matures to adequate flow volumes, and then bring them back in a 2nd stage to superficialize it or tunnel it laterally to make it a usable access. Forearm loop grafts, I like this one. This is, in my opinion, a very good graft for morbidly obese patients. Oftentimes the forearm is less obese than the upper arm. Just the weight of the arm can be floppy, it can move around, it can be enough that it kinks the medial aspect of your graft. The forearm, I found this to be less so. You can plug into the brachial artery, tunnel it onto the forearm in a nice big loop, and then for your outflow, you can use the antecubital vein, you can use the basilic vein, the cephalic vein, or even the deep brachial vein if there's no superficial veins. The upper arm, this is the brake Ax-Graft. You can plug into the artery at the antecubitum and then plug into the axillary vein up in the axilla. This can be done in a straight configuration. It can also be done in a loop configuration to where you use your inflow source up here in the axillary, loop it down and around the arm, and then use the axillary vein as your outflow. So kind of this is what I call exotic accesses. You can get very creative. And people have, especially in this fistula first initiative, you can take saphenous vein from the leg, you can transpose it up to the arm, and you can create any anastomosis or connection you want, either in the forearm or the upper arm using saphenous vein. But the patency is not much better than what I showed you before. It's about 40 to 50% at 12 months. It's not like we're getting 3 to 4 year patencies out of these. You can also take femoral vein from the leg. It's a nice, big, huge vein, and you can transpose it up to the arm. Pretty good patency, 67%. The problem with the femoral vein is that it can be morbid. 2 patients in that series needed fasciotomies. The wound complications of harvesting the femoral vein are about 1 in 4, 1 in 5. So it's a higher risk procedure. You can also take the brachial vein in the upper arm and transpose it. Harvesting the brachial vein is very difficult. There's multiple side branches. Oftentimes it's paired. Technically, it can be time consuming and very arduous to go in and ligate all those veins with 7-over-6-O-proline. You can transpose it, and it does work. The interesting thing is there's a very low risk of forearm compartment when that's done. In the leg, you can use saphenous vein or femoral vein to transpose and create AV grafts. The biggest issue in the groin and the leg is infectious rates. So I got a question, and I'll just read the question. In a patient not on hemodialysis, so not on hemodialysis, just progressing, how many times do you attempt AV fistula before moving on to another option? That's a good question. So for me, it would be, I would try distal AV fistulas first in them if they had vein that was 2 millimeters or above. And I know the maturation rate on that is around 10 to 20% in a vein that small, but it's a 1 in 10 chance for them. They're not on hemodialysis. So I would try both forearms, and then I'd move to their upper arm. If I tried what I consider one good quality vein, upper arm AV access, then I would stop. If they have a 3 to 4 millimeter cephalic vein, I do a brachiocephalic AV fistula in them. It looks great, or a basilic vein transposition, and it looks great. No technical no technical faults, so to speak. It's open and it fails to mature, then I would stop. And so that's going to be about 3 creations, hopefully all done as an outpatient, done with a block. If those do not mature, then I put them on a holding pattern and say, look, they're going to get a graft 1 to 2 months before they go on to hemodialysis.
Hey, Zach, can I add one thing real quick?
Yeah, go ahead.
The other kind of comment for that, which I think it's a good question too, is, if they're not on dialysis and their forearm veins are marginal, sometimes we will try to hook them up knowing that what Dr. Arthur said, it's a low chance, but it will start to arterialize the rest of the arm, making their second attempt higher up a little bit more favorable. And so if you can push arterial flow up, then you try to dilate up the venous system of that arm, giving you a bigger brachiocephalic target or basilic vein target or even forearm target on the next shot.
So back to exotic grafts, you can do some chest wall grafts. I don't really like this configuration to where it tunnels across the sternum. It's very difficult to do that. Depending on how low you put it, if they lay on their chest, it's basically compressing against bone. But this is an option going across the chest in kind of a collar fashion. Other options, this is the one I like, is an axillary loop. This picture really isn't accurate. It's an infraclavicular approach. The only issue here is working around the pec major. The pec major can kink it. Some authors will come from an infraclavicular approach, but then tunnel them underneath the pec major out in a circle and back under. Either way, it is more technical to do this. When I do it, it's in usually a morbidly obese patient, and the chest wall can be a nice alternative. I did get another question. Do you tend to do single stage or 2-stage basilic vein transpositions? Yeah, we do at our institution. We do a single stage if it's a slam dunk. But if it's questionable, we do a 2-stage, and that's kind of my practice. When I do a basilic vein transposition, for me personally, I harvest the basilic vein at least 5 to 7 centimeters distal to the elbow, because when you tunnel it anterior, you need a lot more length than you think to maintain an adequate length basilic transposition. If I do a single stage, I can't really optimize that length. Basically, I have to pick it up at the elbow, plug it into the brachial artery. I have seen some authors that will take the distal basilic vein in the forearm, transpose it over to the brachial artery, distal to the antecubital crease, to try to maximize that. But it's the same for me. If it's a 3.5, 3.7 millimeter basilic vein, my preference is to just go ahead and do it in a single stage. If it's a 3 millimeter morbidly obese patient, then doing it in a 2-stage is reasonable, plugging it up and then seeing what you get. And I think that's pretty common in patients. I do have to say, going back and doing the second stage, I just don't enjoy it. it's just not. I mean, technically it can be done, but it's just not that enjoyable. Depending on how you do it, some people will disconnect it, tunnel it, and then do a vein-to-vein anastomosis. In my experience, I disconnect it from the artery, leave a vein, kind of a vein cuff there so it's flush, tunnel it, and when I tunnel it, I have to attach it to the brachial artery more proximal to keep it from being elongated or stretched or under tension. So back to the exotics, here's some other configurations. You can use the axillary or subclavian artery and then use the IJ for outflow. Again, I don't cross the sternum. You can do this from the neck. Same with the brachial artery. You can also go from the brachial artery, tunneling subcutaneous across the delta pectoral groove can be an issue. You want to stay medial so that it doesn't get put on tension, and use the IJ as outflow. Typically, if you do this, it's because the axillary vein has already been burnt out from a break ax or something like that, and now you need to jump outflow, or you couldn't stent the outflow, something of that nature. But those are options, and I put those all in kind of the exotic type categories. In the legs, I just put these in here for thoroughness. You can use deep femoral vein or saphenous vein to create a AV fistula in the leg. Usually your inflow source is the AK pop or the SFA. Depending on your outflow source is the common femoral vein. This can be done with prosthetic grafts as well in any configuration. You can plug in the AK pop here or the common femoral vein here, which is typically what I do, or you can use a more proximal inflow source to hopefully mitigate the risk of steel and use a femoral vein anastomosis, or just do a loop back into the groin and plug into the femoral vein. And you can kind of see all of those configurations here. Artery to artery, this is something that's always interested me, and so I put it in here for you guys. AV access is a huge problem nationally. We're all looking for ways to do it better, and keeping these things open is treacherous. You would think that creating an AV fistula would be a slam dunk for patency, because usually what dictates the patency of our grafts is the outflow resistance. And the resistance of the right heart when you do AV fistula is essentially nothing. So the flow should be incredible. And so this kind of intrigued me. Well, what if we create, you know, our patency doing a fem pop bypass is better than our patency of doing a break Ax-Graft? Like, how could that be? You know, I mean, what's the difference? Well, it really comes down to the population. We're not doing fem pop bypass grafts in patients that have the comorbidities that dialysis patients do. But this has always intrigued me, doing an artery to artery loop graft. So you just basically divide the artery and do an end-to-end loop graft for the patient. It's been done in the chest wall and it's been done in the groin. And interesting, the patency is pretty good in the selected patients. The thing I was always worried about was distal embolization to the extremity. In one series, they only had 2 patients that when the graft went down, they had limb ischemia from it. But this is an interesting, just more for science and research than anything, as an alternative to AV access.
Hey man, I have a question. I've never done that before. Go back to your picture if you don't mind. What about creating a parallel path? Just doing an end to side, and then not.
Well, with thrombose, you know, we've all done that with competitive flow.
Yeah.
With thrombose, it wouldn't stay open. You've got to have direct inline flow. So yeah, doing a parallel, that would be ideal. You need some way to maintain flow in it.
I've never done an arterial dialysis graft.
No, me either. It's more just for interest. So surveillance is debated. The KDOP guidelines say, hey, we should survey these because surveillance will make our outcomes better. Well, the truth is it really doesn't. There's randomized data that shows no benefit for duplex ultrasound surveillance for prosthetic grafts. The SVS clinical guidelines for hemodialysis say that there's really low to no data for AV fistula. The real issue is you need to have a plan within your system to have incredible communication with your dialysis center, so that if there's an issue, you can intervene on that fistula or graft very early. Usually if there's a 10% reduction in any number that they measure, that's a good metric that something's going on with the fistula to where you need to intervene. So what are the failure modes? Well, flow limitations are the major problem. Right now, most hemodialysis units run their circuit at 500. So it's pulling 500 cc's a minute from the vein and giving it back at that same rate. If there's any recirculation, they'll get inadequate flow. And recirculation is basically when the afferent needle is pulling back and is basically due to poor flows. It's not pulling from the patient's arterial bloodstream. It's pulling from the efferent needle, which is giving the blood back. And so the circuit is basically just taking the clean blood from the efferent, aspirating it back toward the afferent needle in the AV fistula or AV graft, and it's just sitting there cleaning the same blood over and over and over. And after 4 hours of therapy, they really had no clearance. It is important to note that everything changes during hemodialysis. They're usually pulling off large amounts of volume, so their preload is dropping. And usually patients during dialysis, if you look at their flow chart, they're running in pressures of like 90s. So very low cardiac output during this time, and it is a stressful time period for them, which is why the flows on their graft, in my opinion, or fistula in your clinic really need to be 800 to 1,000, because once they get on the circuit, their cardiac output is going to drop, and they're probably going to be in the 600s when it's all said and done. So having a static resting flow volume of 500 to 600 in our clinic, in my experience, usually has not tolerated hemodialysis very well. Venous outflow stenosis is kind of the Achilles heel of all failure modes. And then poor cannulation placement. This can be a technical thing that happens at the center, which is why you need to have good communication with them. This is what an outflow stenosis looks like. Here's a high-grade axillary vein stenosis right here. Significant collaterals filling up around the shoulder, going around. Once you treat that, now you have direct inline flow. You've lost all that collateralization, and the outflow of the fistula is restored. So how do you detect failure? Arm swelling is an obvious thing that something's going on in the central circulation. High venous pressures or prolonged bleeding. At the dialysis center, they always check something called a static venous pressure. And that's at the end of their dialysis. They put in their arterial and their venous cannula. Once the pump is off, everything is clear. There's no forward pressure on that venous cannula. They measure a resting pressure in that AV fistula, and usually they get worried if it's greater than 50% of MAP. So if their MAP is 50, if it's greater than 25 for them, that's a red flag. For me, a 10% increase, you know, the best thing is serial measurements. If their static venous pressure goes up 10%, so if when they start dialysis, it's running 20s, and then it goes up to 25, for me, that's a red flag, and I prefer just to do a fistulogram and see what's going on with the outflow. And really, there shouldn't be a demonstrable change. The other aspect is poor flows on hemodialysis. They will complain about this because it's money. Most dialysis centers are running 3 shifts. They want them to get a 4-hour run. If they have to run them anything less than 500 cc's a minute, they're not going to get cleared in 4 hours. And it's going to take up time, and it's going to take up a bed, and it's going to prevent them from being able to bill for that next time slot. And so this is usually the most common reason they get referred over, is once they can't get their therapy done in an adequate amount of time. You could run them at 300 cc's a minute, but it might take them 8 hours to get the dialysis, and that can be very inconvenient for the center and for the patient. So salvage.
Can I add something really quick on that last slide? So actually, you taught me this about 6 years ago. There was a case that I remember was worried about subclavian vein rupture, and I don't remember the exact reason why, but you made a comment about how pressure dissipates more quickly than people realize as you move proximally to the heart. And so I didn't believe you. And so I remember we did a pullback pressure from the central system all the way back towards the fistula. And my assumption was going to be that central pressures were going to be 30 to 50 just because the arterial pressure was 120. And it wasn't. So the pullback pressures, when you get to the subclavian vein, are down to like 5 to 10, sometimes even back to normal. And so if you have pressures that are that high, 20 to 30, that's
Right.
really abnormal, because you really should have normalization with a central venous system that's open. Your pressures by the time you get to subclavian vein should be basically back to normal. You shouldn't have super high elevated venous pressures. And so I think that's just kind of, I mean, I don't think I learned that in fellowship, in all honesty. And so I just bring it up because I thought it was kind of eye-opening.
Yeah, that's a very good point. So salvage, most salvage is outflow treatment and is done with either percutaneous angioplasty or stenting. The same is true for thrombosed grafts. We can do that very well percutaneous, but all of it can also be done with open techniques. And these are very basic techniques. Everybody should be able to do a thrombectomy on these. Everybody should be able to do a patch angioplasty of the outflow. That little bitty axillary vein stenosis I just saw, you'd be very good for a patch angioplasty. Or you could just do a jump graft around that outflow stenosis to another location, or a revision of some kind. And a patch angioplasty just looks like this. If you treated that axillary vein, you could do it with vein, or you could do it with a nice piece of PTFE. To patch open that venous stenosis, and that's a perfectly reasonable salvage option to keep that fistula going. Complications, arm swelling, venous hypertension, that's indicative that there was a subclinical stenosis centrally that you missed when you placed it. Seroma hematoma infections, those are all pretty common. Hand ischemia or steel, in my opinion, is the most severe. There is a condition that I won't mention called monomaleic median neuropathy. That's felt to be kind of an ischemic syndrome, but is also a major red flag and a huge complication for access. But who's at risk for hand ischemia or steel problems? Well, it's the elderly, the diabetic patient, the patient that has calcified vessels or PAD. It's more common when you use the brachial artery as a donor location, and more common when you use a graft as well. This is what steel looks like. This is a fistulogram done through the brachial artery in a patient that has steel, and you can see that there's zero flow going into that brachial artery. All flow is going into the fistula. If you clamp that fistula, now you can see the native circulation being perfused. And so it's a dynamic problem or phenomena because you've hooked up a low resistive system that is competing with a high resistive bed. Resistance essentially controls everything. And so in this situation, you've created a fistula in a patient that is probably a very good fistula, but it's a marker of the patient having disease in their distal outflow. So most patients, when we put a fistula in them, their hand will compensate. It will fight for this low resistive bed by dropping the resistance in the hand to make the differential more. Make the differential less. But if you already have disease in the hand, then at rest, the hand is vasodilated. So once you put a fistula in it, it cannot compensate any further. And so it's left with a bed that is already maximally vasodilated, competing with new vasodilation. And that's where hand ischemia happens. And so a lot of people get wrapped around the axle that you did something to create this, i.e. your anastomosis was too big, the vein was too big, you name it. In my opinion, it is not a flow problem. It is a resistance problem. And you put in a fixed low resistive bed. There's nothing that you can do to change the resistance of the right heart. It is what it is. And if you do a fistula in it, the real indication that somebody has hand ischemia, steel, or ischemic symptoms in the hand is that they have terrible disease in that upper extremity already that was not fully recognized before you started. So this is what I said, a low resistance system steals from that high resistive bed that is already maximally vasodilated. Steel can kind of span a spectrum of pain with hemodialysis. And why do they get pain with hemodialysis? Nothing changed to the resistance in the hand or in their right heart. What did change was their cardiac output drops. So now their forward flow to that upper extremity that is already compromised becomes ischemic. So if they just have pain during your hemodialysis, the real issue is what's happening during your hemodialysis. The hand is okay throughout the rest of the day when their cardiac output is reasonable. So is there some things that they can do during hemodialysis to make that better? Rest pain, now they've got pain in their hand at rest just every day, and that's a marker that they're going to resolve. Sometimes this rest pain will get better, surprisingly, over kind of a 6 to 12 week period. And if they have tissue loss, for me, that's a red flag and you need to do something pretty soon. So still treatments, if the patient wakes up from their procedure and they have steel symptoms in their hand, I go back and undo it. I'm done. If they have immediate steel after the surgery, I'm out. I go back, I fix it, I'm done. I'm not going to wait and watch and see if their hand pain or hand weakness or hand numbness gets better. Immediate steel for me, I reverse whatever I just did with them, and then that extremity gets a very long holiday for me. And I'm also extremely apprehensive when I go to the other extremity. I know that they have symmetric disease in both upper extremities. When I go to the other extremity, I will use a very proximal inflow source, either the infraclavicular subclavian or the high axillary, to usually do some type of loop graft in the upper arm. Steel treatments, you want to make sure there's not an inflow arterial stenosis and correct it if there is. You can correct distal stenoses, although I've not found this to be very helpful other than a distal stenosis that you caused. So if you clamp the brachial artery and you cause a distal stenosis in that brachial artery from a clamp injury, or in doing your anastomosis, you narrow the brachial artery at the distal aspect to where now you have reduced or created a stenosis, then that can be something that you can correct. An fistulogram and an angiogram would help you sort that out. Other than that, correcting the distal stenosis, in my opinion, has not been all that successful. I have gone down and plastied the radial and the ulnar arteries to get them up to a caliber of 2.5 to 3 millimeters. That has not been enough in my experience to improve their still symptoms. Beyond that, the simplest thing to do is proximalization of the inflow source. Now you're taking your inflow source and you are changing the point at which you're taking the blood vessel, the AV graft or AV fistula off of, in order to change the resistance differential. And that's all you're doing. Selected reports show that if you do proximalizations, this is usually a brachial based, and you're proximalizing it to a high axillary. You want to get above the deep brachial artery of the arm, so you go as high in the axillary as you can. 87% of the accesses were salvaged or maintained, and you got a digital index bump of 0.4 to 0.8. Oftentimes, we will do digital brachial indexes with the graft patent and with the graft occluded, and there's no change. And that right there, for me, I'm not very confident that proximalization is going to work. If I can't get a change by occluding at the bedside, it tells me that they have severe disease, that with and without a pressure differential coming from that AV fistula or taking away their low pressure sump, there's no improvement in their DBI. I'm not very confident that going and doing a procedure to salvage that is going to be successful. This is what a proximalization looks like. This is a brachiocephalic. You disconnect it, usually use a piece of graft. I will go as high in axilla as I can to bring that graft off, tunnel it medial, and then plug it into the fistula so that this is still usable for access. Banding. So the reason I don't like banding and I don't believe in banding is that banding presumes that the flow volumes in your fistula are the problem. And what dictates your flow volumes in your fistula is the patient's cardiac output and the resistance. The resistance in the AV fistula is the same. So the whole concept of banding is that you're going to go in and you're going to reduce the origin of your AV fistula or graft to a point that it becomes flow dependent. And as soon as you do that, now, if it's flow dependent, now you're increasing its risk of it thrombosing. And in order to change the flow in the AV fistula, because it's coming from your brachial artery inflow source, you have to reduce the diameter of that AV fistula to greater than 75% of the diameter of the donor artery. So if your donor brachial artery is 4 millimeters, you've got to get the anastomosis down to 3 millimeters. And in my experience, we're not good enough to be that exact. And one of two things either happen. Either the thrombosis, which is probably okay because then hopefully their still symptoms will resolve, or you won't make a difference and it won't change it. So I have not had success with banding. I don't do banding. I don't like banding. For me, it does nothing to improve the resistance in the patient's hand. All it does is try to reduce or increase the resistance in your AV fistula to make the resistance differential between the hand and the AV fistula graft less. It makes no logical physiologic sense to me, and so I don't do it. I know people do it. I know some people like to do it, but for steel that I'm worried about, I don't utilize it. Drill. This is another procedure that I just will bring up. There's two other procedures you can do: distal revascularization and interval ligation. This is one of them. Your inflow, and so this is basically changing the resistance pattern within the arm. You ligate the distal brachial artery, which just sounds disgusting to me. You maintain your brachiocephalic fistula here, and you do a vein graft from the proximal brachial artery. It needs to be about 10 centimeters from this anastomosis in order to allow blood flow to increase down the arm, and you plug it into either the distal brachial artery in the forearm or into one of the radial or ulnar arteries. This is a lot for me. These fistulas have patency rates of 50% at 12 to 24 months. Ligating a patient's brachial artery, number one, they have steel because they have terrible disease in the radial and ulnar arteries. So now I'm going to do a bypass to terrible outflow. I did them in fellowship. I've done them with people. These patients have 2 to 3 years of survival, maybe 4 years. I'm out. I don't do this. This just made a procedure that really needs to be a minor operation, a major operation in a patient that has high cardiovascular mortality. This is another thing you can do that is actually fairly simple, and in my opinion is on the order of proximalization. My first choice would be proximalization, but you can disconnect it from the brachial artery, and then you can choose a more distal inflow source. So you can choose the radial or the ulnar and do a jump graft back so that now they have a distal inflow source in order to perfuse that fistula. And to me, you can do that in a minor procedure. It's unlikely that you're going to have a good vein conduit to do that with. But maybe in the right place, if this is a brachiocephalic, maybe they have a piece of basilic vein or something like that in the upper arm that you could use to use a distal inflow source. The challenge with the distal inflow source is you really don't get that distal. You need about 3 to 5 centimeters between the takeoff of the radial and the ulnar in order to not steal from the other vessel. And getting 3 to 5 centimeters down either the radial or the ulnar in the forearm, you're really in a thick portion of the muscle bellies of the flexor compartment and can be kind of challenging to do. But I mention it as an option. For me, if a patient has steel, really I have a very low threshold to abandon that fistula and then reevaluate their access plan and look at either more proximal arteries or leg arteries in order to provide them with a fistula. The patients high at risk for steel are the elderly patients with diabetes that have severe disease. And so like Dr. Proper mentioned, I don't think it's a failure to deem them a tunnel catheter patient for the rest of their life either. But just my biases. Okay, any questions? And I'll use the chat function here for any questions.
No, that was really nice talk, man. I appreciate you doing that. The just in terms of steel, the sort of the terminology that I'll throw out there that you may hear used as a student or a resident is high flow steel versus low flow steel. And just to kind of make it sort of simple, if you have a lesion that's proximal to your anastomosis, that is considered low flow, meaning that there's a blockage that's creating low flow into the fistula, and the primary treatment is treatment of that primary blockage, versus high flow steel, which means that there's no proximal inflow stenosis, and so you're getting high flow into the fistula, and that requires different treatments. I'll just leave it at that.
All right, it looks like, go ahead.
Any other questions from the residents? That was a nice sort of comprehensive talk. I think we probably won't, I mean, we don't have another AV access talk actually coming up for a while. So that was actually pretty comprehensive and covered most of it. But if there's any other questions out there, shoot them out now. Tomorrow's talk is splenic artery injury, or splenic injury. I can't remember if McGovern's doing it or McCarthy. They may have switched. So that's a resident talk. And then Thursday is tumor board. I haven't quite figured out yet. I'll have to get with Dr. Vreeland about how tumor board's going to be done. It looks like you got a bunch of, no, thanks, Dr. Arthurs. Thanks.
Yeah, I would say there is one steel that is very rare that, just to mention for the residents, every once in a while it'll happen. You can have steel from a radiocephalic fistula. So you do a radiocephalic fistula and then they have hand symptoms or steel from their hand. One of two scenarios can happen. If they have a palmar arch that's intact, you have to confirm that's intact, then that radiocephalic fistula is stealing from the ulnar artery. And the simple treatment there is to ligate the distal radial artery simply with a clip, a small incision, clip it, and now you've resolved the entire steel syndrome, created a direct inline flow from the radial artery into your radiocephalic fistula, and the ulnar artery is still perfusing the hand. However, if their palmar arch is not intact, then they're just stealing from the radial 1 to 3 digits, and the treatment, in my opinion, is just to ligate the radiocephalic fistula and move forward. So just kind of another rare situation that can happen, you know, steel. Most common steel syndromes off the brachial artery, but it can happen at other locations. It doesn't look like there's any other questions. So guys, I hope you have a good day.
Thanks, man. Appreciate it. Have a good day.
All right, we'll see you.